Hi all. Today we are going to start a question discussions. Okay, this questions is from important files that you have to study for your exams and some previously asked questions too. So first question is, which dosage form is appropriate when maximum moisturization is required? So the question is, for maximum moisturization, if you need the property of maximum moisturization, which dosage form is the appropriate one? So options are ointment, cream, lotion, gel. So the answer is ointment, because ointment has, it is a kind of dosage form in which we will get maximum moisturization. Why? Because ointment has high oil content. Okay, when this there is high oil content, it will create a barrier that helps in moisture making. Okay, and also it will create an intense hydration compared to creams, lotions, and gels. So ointment has maximum moisturization. Other options, cream. Cream also gives moisturization. When we compare it with ointment, it has less moisturization. Then lotion means it is like a watery texture, right? So here more water content is there in lotions. And gel, it is also a 3D water structure. So here the drugs with or the dosage form with the maximum moisturization is ointment. What is the function of small nuclear SnRNA in protein synthesis? So the main function of SnRNA in protein synthesis is modifies mRNA molecules, because SnRNA plays a crucial role in pre-mRNA. So it is done this by by they are participating in a process known as splicing. So what do you mean by splicing? Splicing means it is a complex process of removing introns. Introns means non-coding region and joining exons. Exons means coding region. So here we are making a mature mRNA, mature RNA by what we are doing by removing the non-coding region and attaching the coding region. So the main function of snRNA is the modification of mRNA molecules. Okay. Which of the following polymorphic enzyme is responsible for the conversion of codeine to morphine? For the conversion of codeine to morphine, which one is responsible is the question. So for the conversion of codeine to morphine, the one which is responsible is CYP2D6. So you know that codeine means it is a prodrug and it has analgesic effect depending on the metabolism. Okay. This codeine is then converted into morphine with the help of the CYP2D6 enzyme. And this morphine, it is more potent opioid. Okay, this morphine, it is a more potent opioid. So CYP2D6, this codeine, it is a prodrug and it has analgesic effect, and this is converted into morphine. It is a more potent opioid and it has more activity when we are comparing it with codeine. Okay. So by CYP2D6, we are converting this. Approximately 415 million people have been diagnosed with diabetes. Which of the following terms is referred to the mentioned statement? So here we are mentioning approximately 415 million people. So here we are calculating the total number, right? Here we are calculating the total number. We are not saying about the new cases or anything. We are just calculating the total number. So when we are doing this, what will be the answer? Endemic, epidemic, incidence, prevalence. So the answer is prevalence, because it refers to the total number of cases of a disease in a population over a period of time. So in the statement, if they have said about 415 new cases, if they have mentioned, what will be the answer? It will be incidents. But here they have mentioned 415 million total cases they have mentioned. So when we are mentioning total cases, what it will be? It will be what? It will be prevalence. Now we will check on other option, endemic. What do you mean by endemic? Endemic. Endemic means a particular kind of disease that is occurring in a particular area, okay, or in a community. For example, if you are saying, if you take an example of malaria, it is mostly occurring in an area, slum areas, right? Slum regions, so in the area where there is stagnant water. In all those kind of conditions, in that particular community or in that particular condition, there will be increasing growth of malaria, right? So that is meant by endemic. Endemic means the particular kind of disease or the disease that is regularly occurring within an area or a community. Okay, that is known as endemic. And epidemic, what do you mean by epidemic? Epidemic means what? Epidemics means the outbreak of a disease. Okay, sudden outbreak of a disease is mean by epidemic. If you're saying, for an example, Corona, if we take the condition of corona, what happened? Suddenly there was increased case of corona. There was a sudden outbreak of that particular disease. So epidemic means sudden increase and endemic means that is happening in a particular area because of its particular conditions. Okay. Here the question is 415 million people have been diagnosed with the diabetes. So here they're just asking the total number of cases. So when they're asking the total number of cases, what will be the answer? It will be prevalence. Which of the following is the disadvantages of conducting randomized control trial? So, what is the main disadvantage of conducting randomized control trial? The main disadvantage of conducting randomized control trial is it is expensive because this randomized control trial it is considered as a gold standard for clinical research because there is very less minimized bias. Bias means errors happening in this randomized control trial, and because why there is very less errors because everything is happening in front of our eyes, right? Mostly everything is happening in front of our eyes. We will be having a proper follow up. We will be having a particular group of people who is working for that. So there is a need of large participant, large recruitment, large follow up, large team to do this kind of randomized control trial. So for all this data analysis, follow up, participants, everything what we need money. So it is expensive. This is the main disadvantage of randomized control trial. Which of the following terms measures the association between the exposure and the outcome? The term which is used to measure the difference between the exposure and the outcome is what? Options are p-value, risk ratio, standard deviation, and confidence interval. So here the answer is risk ratio. Risk ratio, it is also known as relative risk. Okay, please note down. Risk ratio, it is also known as relative risk. It measures the association between the exposure and the outcome. Okay, when there is an relationship between the exposure and the outcome, it is measured by risk ratio, relative risk. It always compares the risk of an event occurring in an exposed group to the risk of an event occurring in an unexposed group. Okay, it is compares the risk of an event occurring in an exposed to the risk of an event occurring in an unexposed group. Okay, so all other terms I will be taking class for you. Okay, I will be taking a class for you to understand all these terms, p-value, standard deviation, confidence interval. I will be taking a class on all this. Okay, I will be taking a class on study designs. Which of the following section of a research paper describes the aims and the objective? So the which section in the research paper there is many sections. There will be introduction, there will be discussions, there will be methods, there will be data analysis, there will be reports. Okay, everything will be there. So in that, in which section it describes aims and objective is the questions. So the answer is introduction. So introduction is a section in a research paper that typically describes about the aims and objective of the study. So it clearly provides the background information and it understands the problem and it will outline the goals and it also in the we will understand the goals that is needed to be achieved. Okay, so introduction is the section. Okay, now some questions related to pharmacoeconomics is there. So before that, we will be knowing. So what do you mean by pharmacoeconomics? Pharmacoeconomics means it is defined as the study of the cost and outcome. So in a pharmaceutical product or in a pharmaceutical service, the main important thing or the main important factor is about the cost. Okay, because it is expensive, right? So pharmacoeconomics means it is a study which is related to the cost, which is related to the money and the outcomes related to it. Okay. So the main objective of this pharmacoeconomics is to evaluate, to assess the value of the drugs and the treatments in a healthcare. Okay. In a healthcare, we will be giving treatment. So we need to assess the value of the drugs and the treatment and also to optimize the resource. Okay. This is the main objective of pharmacoeconomics. In pharmacoeconomics, what do you mean by cost? Cost refers to the monetary value of a resource, the amount of money that we are spending. That is simply meant by cost. So there are different kinds of cost: direct cost, indirect cost, and intangible cost. So we will be going to know one by one about that. Direct cost. So direct cost means the cost that is attributed directly for the treatment. Okay, the cost that is attributed directly to the treatment is known as direct cost, that is for a specific disease or a condition. For example, if you are checking if someone from our family got a disease, okay, and they're admitted in the hospital, okay, So the cost that they are using directly, for example, to pay the for the medications, the hospital stay, the doctor consultation, the diagnostic test. Okay, all those, which what we are doing, we are directly giving money for the improvement of patient, right? For the medication we will be paying, for the hospital stay we will be paying directly, which will be related to the patient. Okay, so that is meant by direct cost, that is directly attributed to the management. So direct cost, first one is direct medical cost, that is met by healthcare services. So second one is direct non-medical cost. Now, what do you mean by direct non-medical cost? For example, if I am saying, if I got a fever, okay, so I need to go to the doctor. So the amount I am spending for consultation, for hospital stay, and for medication, it comes under direct medical cost, because directly for my treatment optimization, I am paying. So it comes under direct medical cost. But if I'm getting fever, I need to travel from my place, from my home to the hospital, right? So the travel charge is there. So that the travel charge, what we are giving it to the driver, or we are maybe we will be putting petrol, and also for all those we are, what we are doing, we are giving money. Okay, so that money is known as direct non-medical cost. Here we are not directly paying it to the hospital, but for this same purpose we are giving, to take me to the hospital, we are giving the amount. So that is meant by direct non-medical cost. Okay, understood, right? So if I am getting a fever, I will be going to hospital, so I'll be paying hospital stay fee. I'll be paying for the doctor consultation fee. I will be paying for the medication. I'll be paying for the any test. Okay, lab values or lab test. I will be paying. So everything comes under direct medical cost, and the traveling charge. Okay, I will be going from my home to the hospital. Okay, the travel charge, and also after hospital also, if I am so weak, I need to keep a caretaker to take care of me, or a nurse. Okay, so I need to give them amount. Okay, they will be coming to my home and they will be taking care of me, the caretaker and all. So that cost is known as direct non-medical cost. Okay. Now, indirect cost. Indirect cost means it arises from the consequence. For example, if I'm saying, like, I got a fever. Okay. So what do you mean by direct? Direct means the hospital bills, and indirect means direct medical, and direct non-medical means what? The travel expense and all. Now, indirect cost means if I am not well, I'm a working woman, right? So I need to take leave from my workplace. So when I'm taking leave, my salary, what they will do? They won't give me that day's salary because I'm not working, right? So there also I got a loss of money. Okay. So that is meant by indirect cost. Okay. Now just think, if for a small kid and all, if they are not well, their father and mother both have to take leave. So both parents, what is happening? They are getting money loss because of their absenteeism. So that is meant by indirect cost. Okay, loss of productivity or absenteeism, it is meant by indirect cost. Now, intangible cost. Intangible cost means it doesn't refers to the monetary value. We are not referring intangible cost based on the monitoring value. Okay, what we are doing here, we it refers to the pain, the suffering, the emotional distress, the reduced quality of life. Okay, or the social isolation, the physiological factors, everything is included in this intangible cost. It refers to the pain and suffering that we have undergone at that particular time when we got a disease. So that is meant by intangible cost. Okay. So I hope you understand direct cost is of two types: direct medical and direct non-medical. Direct medical means the medications, the hospital stay bill, the doctor consultation, diagnostic test and all. And direct non-medical means the travel expense, the caregivers cost and all. And indirect means the absenteeism or the less productivity at work, okay, due to illness, is known as indirect work. And intangible means the pain, the suffering, the social isolation, the psychological related factors and all that comes under intangible cost. Now, pharmacoeconomic evaluation methods. So what are the pharmacoeconomic evaluation methods? There are four kinds of pharmacoeconomic evaluation methods. The first one is cost effectiveness analysis. So cost effectiveness analysis means here what we are doing here, we are comparing the cost of a drug related to its clinical outcomes. That means if a person is having a disease, just consider he is having severe viral fever. So the doctor is saying if we are taking treatment A, it will cost around 50 rupees. The disease will be cured, but it will take almost 10 days. Okay, so treatment A means the disease will be cured, but it will be taking 10 days. And treatment B, okay, treatment B, it cost 100 rupees. Treatment A, it cost 50 rupees, but treatment B, it cost 100 rupees. So doctor is saying if you are taking this treatment B, it is a bit costly compared to treatment A, but the disease will be cured within 2 days. So what you will do? Here, what you are doing here, we are comparing the cost and also we are comparing the effectiveness, because if we if that person got cured in a short period of time, he can go back to his work. He can do his daily activities, right? He can have a disease free condition at a very instant time, right? When he's opting for treatment B rather than treatment A. So here we are just not at all thinking about money, we are thinking about that effectiveness also. So sometimes we'll be opting treatment B. So that is known as cost effective analysis. Okay. Now cost utility analysis means just not this. Mostly questions related to cancer and all. Cancer diseases coming under this cost utility analysis, because in cost utility analysis we are comparing QALY. QALY means quality adjusted life years. Okay, QALY means quality adjusted life years. Say, if a patient is having cancer and the doctor is saying if you take treatment A, what will happen? He will live for 10 years. Okay, treatment A, if he is taking, he will live for 10 years, but that 10 years he will be need to take chemotherapy, he have to take medicines and all. Okay, that is the treatment A condition. And treatment B, the doctor is saying if you are taking treatment B, the patient can only live for 6 years. But that 6 years, the treatment will be living like a full quality, like the treatment will be, the person will be living like a normal person. He does not need to take medicines, he does not need to take any other therapy and all. Okay, so understood, right? Treatment A means he can live for 10 years, but it's like a sick person life. Treatment B means he can live only for 6 years, but 6 years like a normal people. So many people who are in that condition will be thinking to live how to live normally. They will be thinking they can live 6 years is fine, but that 6 years they can be living with full health. What so here what they're doing, they're adjusting their life years with quality. Okay, so here they are adjusting the life years with quality. That is known as quality adjusted life years. Okay, so mostly for cancer treatment, this kind of CUA questions are asked. Now, cost benefit analysis. Cost benefit analysis means we are comparing the cost with the benefit. Okay, here we are thinking about the monetary values also, because we are thinking about the money, the benefit we are getting from the money. That is known as cost benefit analysis. The last one is cost minimization analysis. So I'm saying an example about cost minimization analysis. We know that there are two kinds of medical stores, right? One is a generic stores and another one is a brand store. So if you're going and buying medicine from the generic store, it will cost you less compared to the brand store. So the minimization analysis means if I got fever and I need paracetamol, from generic store I will be getting paracetamol for 10 rupees. Okay. And from brand store I will be getting paracetamol for 100 rupees. So we will be continuing about cost minimization analysis. So in minimization analysis, I need a drug, for example, paracetamol. So for paracetamol, from generic store, I will be getting paracetamol for 10 rupees, and from brand, I will be getting it for 50 rupees. Both the drug has same active ingredient, same effectiveness in our body, just the rate difference is there. So most people will be choosing what generic drug because it is of less cost when the effectiveness and everything is same. When we are opting for the less cost drug, okay, that is meant by cost minimization analysis. Okay, so these are the four pharmacoeconomic evaluation methods. Now, next one is QALY, quality adjusted life years. So, this QALY here, what we are doing here, we are thinking both about the cost and the effectiveness. So effectiveness here meant both quantity and the quality of the life. Okay. Here we are thinking about the length of life and also we are thinking about the quality. If you are living it for 6 years or 7 years also, we are thinking about the quality that we are living. So that is meant by post utility. That is meant by QALY because here we are doing what we are adjusting the life years for a better quality life. Okay. So mostly it comes under post utility analysis CUA. And just think mostly cancer related questions are coming. Mostly, I'm not saying every questions, but mostly the answer is related to either QALY or CUA, post utility analysis. Okay. Now, this kind of questions has also been asked incremental cost effectiveness ratio. ICA. So, incremental cost effectiveness ratio, it is a term used in pharmacoeconomics. It is to understand. Okay, just think the additional cost that is needed to achieve the extra unit of benefit. That is meant by incremental cost effectiveness ratio. Here, we are paying an additional cost. Sometimes we'll be going to one hospital and the hospital management will be saying us to shift to another hospital. Why they will be saying that? So that our there will be an extra benefit. So to shift from one hospital to another hospital, there needs an extra pay, right? Because that other hospital will be having more facilities than the hospital that we have previously came. So there will be extra pay. But still, this incremental cost effectiveness ratio means the extra cost that is needed to achieve one extra unit of benefit. That is meant by incremental cost effectiveness ratio. Okay. So the questions related to ICA, incremental cost effectiveness ratio, has also been asked. So now we will go back to the questions related to pharmacoeconomics. Which of the following pharmacoeconomic studies is the simplest because of the outcomes are assumed to be equivalent and only the cost of intervention are compared? Here they are saying the outcomes are what? Equal. Okay, the outcomes is assumed to be equal and the cost of intervention are compared. So here outcome is same, cost we are comparing. So what will be that? And also it is the simplest study. So it will be cost minimization analysis. So cost minimization analysis, CMA is the simplest type of pharmacoeconomic study. Here what we are doing here, we are comparing just the cost. Now, which of the following studies represents cost effectiveness analysis? So here which one represent cost effectiveness analysis is the question. Options are comparing cost for two therapeutically equivalent products, comparing cost and savings of a pharmacist serve versus comparing patients achieving control as the outcome for two anti-hyperglycemic drugs, comparison of cost of two chemotherapy regimen with the cost of using best supportive care. Here, first one is comparing cost for two therapeutically equivalent products. First of all, what will be the answer? The question is represents cost effectiveness analysis. So here the best one to represent cost effectiveness analysis is C, right? Here we are comparing patients achieving control as the outcome of two anti-hyperglycemic drugs. Here what we are saying, maybe in this means the option means the patient will be taking one anti-hyperglycemic drug at once. At that time he might not be having any outcome, that the outcome that is needed, maybe his blood sugar will be reduced, but that particular outcome, right, that is needed is not achieved. So what the doctors is doing, the doctor is again adding one more anti-hyperglycemic drug. Now the patient is taking two anti-hyperglycemic drugs. So when he is taking two anti-hyperglycemic drugs, the outcome is reached. Okay, the goal is achieved. And the patient, what they are doing here, when they are giving one drug, a particular outcome is achieved, and they're giving two more drugs, particular outcome is achieved. Okay, so the cost is increased here, right? Because to buy one medication there will be either 10 to 20 rupees. For two drugs the cost will be more, but when the cost is more, the effectiveness also they are getting, right? The effectiveness also they are getting. So for cost effectiveness analysis, the perfect example is option C. So what will be option A? Comparing cost for two therapeutically equivalent drugs. Therapeutically equivalent drug means what? The outcomes are same, so it will be cost minimization analysis. Comparing cost and savings, that is cost benefit analysis. Then comparison of cost of two chemotherapy regimens. So mostly the chemotherapy or cancer related questions, it is for cost utility analysis. Okay. Then what type of costs are traveling from Jeddah to Riyadh to healthcare from a pharmacoeconomic perspective? From a pharmacoeconomic perspective, the cost of traveling from Jeddah to Riyadh is indirect, intangible, direct, non-medical, non-direct medical. So what it will be? Direct, non-medical cost. So here, that particular patient is traveling from one place to another place for the treatment, right? So it is direct, non-medical cost. Now, which of the following statement provides the best described incremental cost effectiveness ratio? So the incremental cost effectiveness ratio is bestly described by what? It is the extra cost for an extra benefit. So option B will be the answer. The extra cost obtained for an extra benefit by switching the alternative or switching to one hospital to another. Okay, whatever it will be. So the extra cost that we are paying to get an extra benefit. So we are not simply paying the cost. We are paying the cost and we are getting that benefit. So that is meant by incremental cost effectiveness ratio. Now, in pharmacoeconomics and outcome research, QALY are used as utilities. So, QALY is the quality adjusted life year. Which of the following is an interpretation of an individual with? So, QALY, that is quality adjusted life years, means what? What is that interpretation means is the question. Death, coma, illness, perfect health. So, what will be the answer? Simple it is. Quality adjusted life years means perfect health. Now, next question is a 25-year-old man with leukemia was admitted to the Hematology Oncology Center. Who is allowed to read the patient file without additional permission? So, here a 25-year-old man with leukemia, he was admitted to the Hematology Oncology Center. Now, who is allowed to read the patient file is the question without additional permission. So, options are patient consents, who is working as outpatient nurse in the hospital, medical resident in pediatric who wants to explore the risk leukemia, clinical nutritionist who is assigned to calculate the requirement for the patient, pharmacy resident who is planning to do a research about cell transplant. So here the question is, who is allowed to read the patient file without additional permission? So here the answer is option C, the clinical nutritionist who is assigned to calculate the requirement for the patient. Why we are saying that? Because here the person who is assigned to check the patient's file without permission is the one who is taking care of that patient, right? So here, clinical nutritionist is directly linked to that patient because to get the relevant information for the proper diet, she need to check the patient's file to assess about the clearance value and all other things, the height, weight, and everything she need to first understand. Then only she can prepare a diet or the proper nutritionist requirement that is required for the patient for the proper welfare or the for the proper treatment of the patient. Okay, so clinical nutrition is the one who is assigned to calculate the requirement for the patient's need. So she is the one who is able to take the patient's file without taking permission. When we check all other options, one is patient's cousin, even though she is working as a nurse in an outpatient facility, she is working, right? She's not directly involved in that patient's welfare. So, patient's cousin, she can check, of course, she can check, but what they need permission. Then, second one is medical resident pediatrics. She's working in pediatrics department, even though he is checking for leukemia risk. She need permission. After taking permission, they can do three. Then pharmacy resident who is planning to do a research. Also, they are thinking about this disease and they can take this file because it is also related to leukemia. So they can take this file because everything that is needed for them, their study can be there in this particular patient's file. They can take the file, but after permission. So the only person who can take this file without permission is a clinical nutritionist, as she is assigned to calculate the requirement for the patient's needs. Okay.